Hi everyone, today we will discuss regarding common rheumatological emergencies. According to the American Medical Association, emergencies are defined as those situations that place the life of the patient or an organ function in immediate danger. Failure to provide care may lead to the death of the patient. Rheumatological condition can sometimes present as emergencies. These may be due to the flare-up of the rheumatic disease or medical emergencies in patients with rheumatic diseases, first presentation of the rheumatic disease, or iatrogenic. A good understanding of these conditions is of paramount importance for the proper management. Today we will discuss regarding the common rheumatological emergencies, starting with case-based discussion followed by a brief description with more emphasis on their treatment. So let's start with our first case. A 70-year-old female with a background history of type 2 diabetes mellitus and hypertension. She was referred to the ophthalmology with sudden loss of vision in the left eye. On further inquiry, she had history of jaw pain and malaise. Fundoscopy revealed pale edematous disc. Her ESR and CRP were significantly raised. She was referred to the rheumatology department for further assessment. What is the most likely diagnosis in this case? She was diagnosed as a case of giant cell arteritis. Which further investigation will you do for her? She will need either ultrasound scan of temporal artery and its branches or temporal artery biopsy. What is the most appropriate initial treatment? As she is having ischemic symptom, therefore IV methylprednisolone will be initially recommended. GCA is an inflammatory disorder of the medium to large size arteries affecting people older than 50 years of age. GCA is commonly referred with headache, ischemic symptoms of jaw and tongue claudication, visual changes, diplopia, blurred vision, loss of vision, or stroke. Inflammatory markers are classically elevated. Delay in treatment can lead to visual loss or stroke. Temporal artery ultrasound or a biopsy is required for the diagnosis. Ultrasound scan will show halo sign. Treatment include prednisolone in cases of non-ischemic symptoms or IV methylprednisolone in cases of ischemic symptoms with proton pump inhibitors, bone protection. Tocilizumab IL-6 blocker is recommended in patients at high risk of glucocorticoid toxicity or who relapse. So let's move to our case 2. A 72-year-old gentleman with background history of TIA, rheumatoid arthritis, hypertension, who was on Ramipril, aspirin, and diamicron. He was referred to A&E feeling generally unwell, off legs. On examination, his temperature was 37.8. There is no focal neurological deficit apart from mild confusion. He was having moderate left knee joint effusion. He was referred to medics for admission. Initial investigation revealed that WBC count was 10, CRP 20, LFT's renal function was normal, urine dipstick was negative, blood culture was sent, X-ray knee joint revealed joint effusion, and aspiration of synovial fluid analysis revealed gram staining positive with white cell count more than 50,000 and culture was awaited. A diagnosis of septic arthritis was made. What further question will you ask in the history? Always ask question about the medicine for rheumatoid arthritis, as most of these biologic drugs are not mentioned on the medication list. Always remember that patient on tocilizumab may have a normal CRP with sepsis and a normal body temperature. How will you treat him? Obviously, tocilizumab was stopped, IV antibiotic commenced, and joint was drained. Differential diagnoses of acute monoarthritis include septic arthritis, crystal arthritis, hemorrhosis, reactive arthritis, monoarticular presentation of inflammatory arthritis, and traumatic hemorrhagic synovitis. Septic arthritis is an infection of the joint, usually bacterial. It's a medical emergency. with a mortality of 10 to 15%. It can present as subacutely over 1 to 2 weeks with painful swollen red tender joint with restriction of movement. 85% present as monoarthritis with knee joint, the most common one, followed by hip and ankle joints. Fever is absent in about 50% of the cases. Always look for features of infection elsewhere in the body. Investigation includes synovial fluid aspiration for gram staining and culture before starting antibiotic. A possibly infected prosthetic joint should always be referred to the orthopedic surgeon. Generally, WBC count is higher than 50,000 with a predominance of neutrophil in cases of septic arthritis. Treatment include non-weight bearing, analgesia, IV antibiotic following joint aspiration according to the local guidelines. The choice of antibiotic is determined by the isolation of the pathogen and antibiotic sensitivity. Typically 2 weeks of IV antibiotic is given, followed by 4 weeks of oral antibiotic. Septic joint should be aspirated to dryness as often as required. Surgical removal of the infected prosthetic joint may be required in some cases. Our next case is a 35-year-old female who came to A&E with a history of polyarthritis of 3 weeks duration, feeling unwell, feverish, no history of skin rashes, no history suggestive of connective tissue diseases. On examination, there was synovitis of the multiple small and large joints with effusion. Fever was 39. Systemic examination unremarkable. Investigation revealed that white cell count, platelet counts were slightly low. Creatinine was 88. CRP was elevated at 120. Urine and blood culture were negative. Right knee joint was aspirated. Culture and gram staining were negative. Rheumatoid factor was negative. Serum ferritin was 254. Urine dipstick was strongly positive for protein, but there was no active urinary sediments. Urine PCR was 300. What other tests would you recommend to make a diagnosis? ANA anti-dsDNA antibodies were strongly positive. ENA with anti-Smith antibodies were strongly positive. Complement levels were normal. What is the most likely diagnosis? She was diagnosed with SLE, and a renal team performed a kidney biopsy which revealed class 3 focal glomerulonephritis. How will you treat this patient with lupus nephritis? She was commenced on mycophenolate and prednisolone, and she responded to the treatment. SLE is the prototypic multisystem autoimmune disorder with broad spectrum of clinical presentation encompassing almost all organ and tissues of the body. Clinical features include constitutional symptoms and symptom as per involvement of the organ system of the body. Proteinuria of more than 500 mg per 24 hours, especially with glomerular hematuria and or cellular cast, should be an indication for first renal biopsy in patient with lupus. Lupus nephritis is further classified into 6 classes. Treatment of lupus nephritis include mycophenolate or cyclophosphamide in combination with glucocorticoid. ACE inhibitor or ARB is recommended in patient with proteinuria or hypertension. Let's start with our case 4, a 45-year-old female with recurrent fever lasting 3 to 4 weeks that occur 2 to 3 times a year, accompanied by sore throat, arthralgia, and recurrent bouts of generalized itchy erythematous rash. There was no history of pleuritis or genital ulcers. Her vital signs were stable. There was erythematous rashes with dermatographism and mild tender knee joints. CRP was elevated. Rheumatoid factor, CCP antibodies, ANA, ANCA were negative. ALT was slightly elevated. Urine showing mild proteinuria. Ferritin was grossly elevated at 7,500. CT cap revealed mild splenomegaly. Skin biopsy revealed an urticarial process with negative IMF. Genetic testing were negative. Based on the above history, what is the most likely diagnosis? She was diagnosed with adult onset stale disease. How will you treat this patient with adult onset stale disease? She was initially commenced on prednisolone, which was switched to colchicine and methotrexate. In spite of the treatment, she was still having fever and getting recurrent joint flare-up. Therefore, she was later on switched to tocilizumab. Adult onset stale disease is a rare multisystem autoinflammatory disorder of unknown etiology. It's a diagnosis of exclusion, more common in female with 2 age peaks. Stale disease is characterized by the classic triad of high spiking fever, joint pain, and rash. Other features include pharyngitis, lymphadenopathy, myalgia, splenomegaly, hepatomegaly, weight loss, pleurisy, abdominal pain, and pericarditis. Different classification criteria are used. The common one are Yamaguchi criteria and Fortran criteria. Yamaguchi criteria is most widely used due to its high sensitivity. Investigation of adult onset stale disease will reveal that white cell count is at least more than 10,000 with predominant neutrophilia, anemia, raised inflammatory markers, elevated liver enzymes. Glycosylated ferritin level is less than 20% of normal, and ferritin is more than 500. Adult onset stale disease is diagnosed by excluding infection, malignancy, and other systemic disorder. Patients with mild disease may respond to NSAIDs alone, but most of them require at least a low dose of glucocorticoid for better control. Patients with moderate disease require DMARDs, and patients with severe disease having life-threatening organ involvement require intravenous immunoglobulin, IV methylprednisolone, and biologic such as IL-6 inhibitor, anakinra, IL-6 inhibitor, tocilizumab, or anti-TNF. Now we will move to our fifth case, a 45-year-old gentleman who was previously fit and well, presented with fever, cough, shortness of breath. On further inquiry, he was having some skin lesion on his arm and legs with joint pain and swelling in the ankle and knee joints. He was generally unwell. He was non-smoker. His initial investigation revealed that hemoglobin was 10, WBC count 10.5, CRP was elevated at 120, UNEs and LFTs were normal, urine dipstick showing protein 2+ with more than 5 RBC. Blood culture were negative. ANCA was strongly positive, as positive PR3 ANCA. Chest X-ray revealed patchy opacification, which was followed by a CT chest, which revealed possible pulmonary hemorrhage. His vitals were stable. There was synovitis of the ankle and left knee joint and palpable purpuric rashes on the limbs. Chest examination revealed bilateral crackles. What is the most likely diagnosis? He was diagnosed with granulomatous polyangiitis, that is called GPA. How will you treat this patient? He was initially started on IV methylprednisolone and rituximab, to which he responded. The term pulmonary renal syndrome is used to describe the development of renal failure associated with respiratory distress, characterized by rapidly progressive glomerulonephritis and diffuse alveolar bleeding secondary to an autoimmune process. Immunopathologically, there are 3 distinct types. Type 1 is antibody mediated. The prototype is anti-GBM disease. Type 2 is immune complex mediated. The prototype is SLE. And type 3, which is post-immune, and the prototype is ANCA-associated vasculitis. The most frequent causes of pulmonary renal syndrome in adults are vasculitis associated with ANCA antibodies. Vasculitis, or a group of conditions characterized by inflammation and necrosis of the blood vessel. They are classified into large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. They are multi-system disease. No organ or system is spared. It may affect many organ systems, since any type, size, and location of vessel may be involved. Differential diagnoses include endocarditis, HIV, malignancy, drugs, cholesterol emboli, and antiphospholipid antibody syndrome. Investigation include blood tests such as baseline bloods, inflammatory markers, serologic testing for autoantibodies, and to rule out other conditions, imaging studies of the involved organ system, and tissue biopsy of the affected organ. Two of the above tests should be present for the diagnosis of vasculitis. Treatment include remission induction therapy and maintenance therapy. Remission induction therapy depend on the severity and organ involvement. Usual medication include cyclophosphamide or rituximab along with IV methylprednisolone and followed by oral prednisolone. Maintenance therapy is usually with methotrexate, mycophenolate, or azathioprine. Plasma exchange is recommended in patients with severe renal failure and pulmonary hemorrhage. Let's move to our last case. A 60-year-old female with a background history of SLE who was stable on hydroxychloroquine presented to the hospital and was admitted to the medical ward with fever of 2 weeks duration, pain in her knee joints, generally unwell and drowsy. Temperature was 39. GCS was 12 out of 15. There was no focal neurological deficit. Investigation revealed that hemoglobin, white cell count, and platelet were low. CRP was elevated with procalcitonin normal. Creatinine was high with a rising trend. ALT was elevated. Urine showing 1+ protein. Blood culture and urine culture were negative. Autoantibodies including ANA, ANCA, and APLA were negative. Chest X-ray was normal. This was followed by a CT cape which revealed mild splenomegaly. Later on, a lumbar puncture was done that revealed that CSF is normal and MRI brain was normal. What other tests will you do to support your diagnosis? She had further tests including triglyceride level which was high, fibrinogen level which was low, ferritin high at about 2000, and soluble CD25 was elevated. A bone marrow biopsy was performed that revealed hemophagocytic cells, and she was diagnosed as having macrophage activation syndrome. How will you treat this patient? She was initially commenced on IV methylprednisolone and intravenous immunoglobulin. Hemophagocytic lymphohistiocytosis is divided into primary and secondary HLH. Primary or familial HLH is an inherited disease, while secondary HLH is triggered by other diseases including infection, malignancy, and autoimmune diseases. Macrophage activation syndrome is a form of secondary HLH which is associated with autoimmune diseases. Macrophage activation syndrome is a rheumatologic emergency with a very high mortality. Features include fever, pancytopenia, splenomegaly, transaminitis, raised inflammatory markers such as CRP, high ferritin, hemophagocytosis, and bone marrow biopsy with high LDL and fasting triglyceridemia and low fibrinogen level. It may be associated with neurological dysfunction, acute respiratory distress, or renal impairment. Two criteria are used for classification of HLH. HLH 2004 criteria is used mainly for primary HLH, and H-score is mainly used for secondary HLH and macrophage activation syndrome. Treatment includes supportive therapy at ICU, IV methylprednisolone or dexamethasone, intravenous immunoglobulin. Second-line treatment include anakinra. Third-line treatment include cyclosporine, etoposide. Other treatment options include cyclophosphamide, rituximab, and plasmapheresis. Treatment of underlying conditions such as infection and autoimmune condition is recommended. Referral to hematology is recommended for bone marrow biopsy and to consider etoposide in cases of refractory disease. Thank you very much.